السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على خاتم الأنبياء والمرسلين. I would like to welcome you all for our SSPD webinar today. I am Dr. Manal Al Malik. I'm a board member of the society and a consultant pediatric dentist at King Fahd Armed Forces Hospital in Jeddah. Today's webinar is organized by the Saudi Paediatric Society and with Kunuz Ritaj Company. Please note that all participants will be receiving certificate of attendance of tonight's webinar by email in 1 to 2 weeks. And it's really a pleasure today to moderate this session with one of my colleagues, Dr. Ali Zahrani. I will be moderating the first presentation, and Dr. Ali will moderate the second presentation. Dr. Ali is a consultant in pediatric dentistry at the Security Forces Hospital in Mecca, and he's a director of academic affairs and training at the Security Force Hospital. And he's also a member of the Western Region Committee of the Saudi Board in Pediatric Dentistry. Please note that at the end of each presentation, there will be time to answer some of your questions. And you can use the section of Q&A to write questions that you have. Okay, we go to our speaker. Our first speaker is Dr. Anas Al-Salami. Dr. Anas is a consultant pediatric and special needs dental surgeon at Postgrad Dental School at Mohammed bin Rashid University of Medicine and Health Science and Dubai Dental Hospital in Dubai. He's a PhD candidate at Queen's University Belfast, Northern Ireland, UK. And he obtained his master's degrees in 2017. He's also a member of the Royal College of Surgeons of Edinburgh and Ireland. He has published more than 20 scientific papers in international journals and published 2 thesis books. He's also a member of committee the IADR. Please, Dr. Anas, you can start, you share your screen, please.
Assalamu alaikum. Can you hear me now? Yes, thank you, Dr. Manal and Dr. Ali and Dr. Ahmed for inviting me. It's always a pleasure to be with my colleagues in Saudi Arabia. So today we'll be talking about so our today topic is about the pediatric dentist evolving role in the managing the cleft lip and palate. And we know that the cleft lip and palate is quite common. We do see in our hospitals, and dealing with these children, it's really challenging, and it's required interdisciplinary approach. So pediatric dentist role is one of the key roles in the management of any child with cleft lip and palate. So we'll be going through that today. So in general, if you look at the incidence of the cleft lip and palate worldwide, it really varies. But when you come to that, I mean, the variation is usually it comes with the race. So in general, the cleft lip and palate incidence worldwide, it's 1.3 per 1,000 birth. And as per the race, it also varies. In Japan, it's 20 per 10,000, and in Western Europe also we have 12 per 10,000. And in US, it's also very similar to Western Europe. And in the Africa, it's 3 per 10,000. And when it comes to the type of the cleft, the isolated cleft lip, only it's the incidence is around 3 to 4 per each 10,000 births. And the cleft lip and palate, so it has been shown that the incidence of having a cleft lip and palate is more common, and the incidence is higher, which is almost double of the incidence of having a isolated lip alone. Well, when it comes to also the gender differences, the cleft lip and palate, when the palate and lip both are involved in the cleft area, usually the males are the predominant. They are this more common in the males. But when it's only the cleft palate only without cleft lip, usually it's involved in the females. So females, since they are more concerned about their aesthetic and appearance, they are lucky that if they, God forbid, if they get a cleft lip and palate, they are more common. Well, most probably they will be getting a cleft palate only and without involving the lip. So in the UK, also according to the type of the cleft lip and palate, they found that the most common cleft type is the unilateral cleft lip and palate is the most common, followed by cleft palate, and the rest are usually around 10% compromise of the 10% of the total prevalence. And in Saudi Arabia, also there was a systematic review by Sabag et al. If we talk about the prevalence and incidence of the cleft and palate in our region. So in Saudi Arabia, there were included 8 studies in the systematic review. 3 were in the Saudi Arabia, in Riyadh, and 2 were in the 2 regions of the Saudi Arabia, which are in Riyadh and Al Qasim. The other 5 studies were from the UAE and Oman and Jordan. So the prevalence that was reported in this study, it was from 0.3 up to 2.4 per 1,000 live birth. So which is very similar to the worldwide prevalence that we have. And the prevalence of the orificial cleft in males was higher than the females. And the isolated cleft was also higher in females here and in most of the studies reported in our region. So which pregnancy or which infants are more at a high risk of developing cleft lip and palate? So going back to the etiology of the cleft lip and palate, there are many reasons, or it can be genetic, it can be environmental, or it can be isolated pattern. But the risks that are already reported in the literature are usually if they have the consanguineous unions or the marriage, and smoker mothers, they are at higher risk. Diabetes, or specifically gestational diabetes or uncontrolled diabetes, they found that they have higher chances. And also they found that when the gestational diabetes, it's very common. Almost 20% of in the UAE pregnancies, during the maternity they have gestational diabetes, and one of the complications of gestational diabetes or negative outcome is macrosomia, when the child birth weight is more than 4 kgs, and they found that in these children also with macrosomia, when they are born, they are at higher risk of having cleft lip and palate. And also those mothers who are using medications like anticonvulsants, also it has been shown that's one of the risk factors, and the increased maternal age and deficiency of certain vitamins, and specifically the folic acid deficiency. It's very important, and as a prevention, using a folic acid 3 months before pregnancy, it has been proven to be really preventive in developing cleft lip and palate in their offspring children. So if you go back to the etiology or embryology of the cleft lip, and if we know that the lip it's formed from the frontonasal processes and maxillary when they fuse. So any disruption in their fusion or failure of the fusion, the median nasal and frontonasal processes with the maxillary, it leads to the cleft lip. And cleft lip, it can involve the alveolus or the premaxilla plus minus, and that's depend on the if it is complete cleft or in the complete failure of the fusion, or it's partial. If it is complete, then definitely will involve the primary palate as well. So again, the cleft palate, if you go back to our biology courses during undergrad, if you can see here, that's a tongue when it's between the two shelves of the palatal shelves of the maxillary process, and by the time the tongue goes down and the palatal shelves fuses. So any interruptions in this fusion will lead to the cleft palate. So can we diagnose the cleft lip and palate at the prenatal stages? The answer is yes. And now in most of the cases, it's common. It's common that to be diagnosed early before the birth during the prenatal stages by having the two-dimensional and three-dimensional ultrasound. It's very easy now to detect. The accuracy of the 3D ultrasound is 100% in detection, and if you are using the 2D, the conventional ultrasound, the chance is up to 75% detection rate. So which type of the cleft can be detected? The cleft lip palate, if it is involved the cleft lip and alveolus, it's much easier. But if it is only cleft palate without involvement of the lip and alveolus with two-dimensional, it's not easy to be diagnosed. So the classification of the cleft lip and palate, there are many classifications, and you can classify it according to different categories. So you can have it classified according to the type, which is you can have either cleft lip, it can be cleft palate, or it can be cleft lip and palate. And according to the location, if you have in the primary palate or secondary palate. The primary palate, which usually it's also involved the cleft lip and alveolus, and usually if it is lip plus minus alveolus, it can be, as we said, depend on the if it is complete failure of the fusion or partial failure. And the cleft location in the secondary palate, it can be hard palate, soft palate, or it can be only in the uvula. So also according to the laterality, also you can classify that it can be unilateral, bilateral, or midline cleft. Or according to severity, the classification also involves either it is a complete cleft or an incomplete cleft. The other type, which is in many cases, it's stayed undiagnosed, and it's very hard to diagnose it at prenatal with the ultrasound, is the subcutaneous cleft, which it's the defect is under the mucous membrane covering the soft palate, and it can be part of it, or it can be the whole area under the soft palate. And since it is covered by the mucosa of the palates, or usually the diagnosis is in cases that you have bifid uvula, that's an indicator. So if you found that's a clinically visible sign that you can see a bifid uvula. But if you found that, then you have to palpate to find a notch in a hard palate, or in very rare cases, that's very hard to diagnose, if to find a blue or white mid-palatal line here. But it's very hard to find it, especially in children. But the most diagnostic sign to lead you to do further investigation is when you have a bifid uvula. In these cases, usually the problems which are associated is during the feeding, and it also affects their speech and their ear because of the recurrent ear infection sometimes. So the cleft lip and palate, it has according to the phenotype, you can see incomplete lip, or you can have lip and with alveolus, and you can have unilateral cleft lip and palate, and you have bilateral here cleft lip and palate. and here is the incomplete cleft palate. That's a complete cleft palate. And here what you can see, it's the actually it's these are the labial pit, but here there is a cleft lip which was repaired. And usually these pits, you see them in the van der Waals syndrome. That's a diagnostic feature of the van der Waals, when you can see the labial pit and there, the middle part of the upper and lower lips. So that's one example of the unilateral cleft lip and palate. It involves the lip and the alveolar bridge and the palate, but in one area, the right and left, but it's more commonly to be seen on the left side, and it's more common in males, and less likely it is associated with syndrome, but if the syndrome associated, usually it's the van der Waals syndrome. That's one of the most severe classification of the cleft lip and palate. You can see here that there is a bilateral complete cleft lip and palate. That's one of the most severe classification and hardest to treat and do the surgery, and with the less prognosis and more complications to the child. Maxilla here is, you can see that separated into 3 parts, with the premaxilla area which is protruded, and that's a bilateral. Also another example of the bilateral cleft lip and palate. Here you can see the severe maxillary constriction. It's almost a V-shaped palate, and they have here the increase, also the palatal prognathus, that you can see. It's aesthetically, usually the children, it affect the children and psychologically, because it's not, they get bullied and teased at the school, and most of them, they avoid going to the school, unfortunately. And you can see here that there is severe extrusion of the premaxillary segment, and in most of the cases, to treat this area, they need osteotomy of the premaxilla. So that's an isolated, incomplete cleft palate, which involve the palate only, but it's an incomplete start from the soft palate. And uvula, it's more associated with the syndrome, usually with the Stickler syndrome, and it's more common in females, as we said initially. The cleft palate only, it's more common in the females, and cleft lip and palate more common in males. And as we said, if it's not the more posterior the cleft it is, the harder to be diagnosed in prenatal diagnosis. That's a complete cleft palate. It's less common than cleft lip and palate, and again, it's more common in females, and again, it's mostly associated with Stickler syndrome, and the diagnosis is also difficult if it is involving the palate only. So those are the types of the cleft lip and palate. So if you think now how we are going to manage them, and who is it usually to have to put a treatment plan and do the management of the child. Management of the child is start before the birth, during the prenatal. Once it is diagnosed with the ultrasound, the management actually starts at that stage, and it might continue up in the 20s and 30s. So it's the management really takes a very long time, almost 2-3 decades of the life of any individual diagnosed with cleft lip and palate. So to manage this individual with cleft lip and palate, you really need to have a team comprised of pediatrician, genetics, nursing, or maxillofacial surgeon, ENT, plastic surgery, psychology is very important, social work, and speech and language pathology. These are the very important specialties that should be involved. And from the dental, other than the maxillofacial surgeon, orthodontics and pediatric dentistry, they are one of the most important team members in this craniofacial team to help because, as you know, the cleft lip and palate, it's affect the oral maxillofacial, oral and facial area. So definitely having a pediatric dentist who can take care of these children from the early stage of their life is very important. So the most common dental problems usually associated with cleft lip and palate, and if you don't see all of them, but most probably you will see most of them, One of them is neonatal teeth, and that's more common to have at the cleft area. Ectopic eruption is very common, especially for the ectopic eruption of the canine, the lateral on the cleft side, if it's not missed, the centrals, primary centrals, usually most of them, they get ectopic eruption, and ectopic eruption of the first permanent molar is very common in these patients to be seen. And supernumerary, it's one of the common dental anomalies also that you can find, and that can be, as usually it's an supplemental if it's in a primary dentition. Oh, sorry, or it can be like a conical shape in a permanent dentition. And also you have the anomalies of the tooth shape and size. Usually some of the teeth are macrodontia and some of the teeth are microdontia. Very common to have in the primary dentition, you have fused teeth, either gemination or fusion, but in rare, less commonly in the permanent dentition. Enamel hypoplasia, it's very common to be seen. That can be either due to the environmental factors during the tooth development for the permanent dentition, or it's sometimes associated with some syndromes, cardiac problems, cyanosis. So there are many factors that will lead to enamel hypoplasia. You know that tooth formation, can be affected with multi-factors can affect the tooth formation. One of them, I mean, it's having a hypoxia, having a surgery on the site, or trauma, environmental. So all these can affect. And MIH is not commonly, it's not very reported in the literature, but we commonly see that. I can say that around 60% of the cleft lip and palate patients, they do have MIH, molar incisor hypomineralization. That's because of the teeth development which happened during the first 3 years of life. These incisors and molars, usually when that's a child, when it goes under general anesthesia, it gets a lot of ear infection and takes for a long time the antibiotics. So definitely that is going to affect the molar and incisors development. So most of the time we see them, they are hypomineralized, and sixes are hypomineralized and ectopically erupted. So early intervention is quite important. Deep bite is very common, and cross bite also. And crowding and spacing. In some areas you might have a spacing, and in some areas you might have a crowding. So all the malocclusion you can find in the children with the cleft lip and palate. So the dental role is start from the prenatal stage. So orthodontics usually at this stage, they have nothing to do. Pediatric dentistry, they have very supportive role in caring the parents and informing the parents about the neonatal treatment options like pre-surgical infant. They need to be prepared other than psychologically. They need to prepare and plan. They need to know that the treatment and surgeries, they start as early as 2 to 3 months after birth. So they need to be prepared of and aware of these procedures that will be going to happen very soon after birth. And it's very important to emphasize on the importance of minimize the transmission of the karyogenic bacteria from the parent to the child, since they are already at a high risk of having dental caries. So we don't want to expose them more to the mucus mutans streptococcus. During infancy also we need to take care of their airway. In cleft lip and palate, usually there is no concern, but feeding and nutrition, it's a problem when you have a cleft lip, because they don't have this, cannot have this pressure, negative pressure, and for the sucking when they lips, they have a cleft in their lips. And they may be able to breastfeed if they have isolated cleft palate. And you need to consider changing their bottle, the bottle for feeding that with the teeth. So these bottles are especially designed for this patient during feeding. Also, the pre-surgical infant orthopedics, which we will be talking more in our next slide. So these are very important pre-surgical orthopedics done before the surgery, early in life, which usually they align these maxillary segments and creates less tension on surgical closure when they plan for surgery to close this and reduce the severity of the cleft. The appliances, it varies. You can use the Latham appliance, or you can use the nasal-alveolar molding or taping. So usually at the neonatal and infant, it starts first week of birth. This appliance usually is inserted and you secure it with surgical tape. And you have the adjustment is done weekly. This activation adjustment is done very frequently, every week or maximum every 2 weeks. So that will allow these segments to come together, and there will be having so report that this will allow the future approximation and surgery will be easier, and the success and will be higher. And this appliance also includes nasal stent, and usually you put these appliances for 3 to 5 months. So still for using the nasal-alveolar molding, there is a controversy in the literature, and it's most commonly now used in the US and in the UK. We don't use it much now because they found that long term it doesn't have any improvement in the occlusion. And so in the mid-face and dental alveolus, it remained the same, and same treatment in long term has been provided regardless of the child had a NAM, nasal alveolar molding, or no. So it is basically now whatever we can see with our colleagues in the cleft lip and palate. It's very, some surgeons they prefer, and some surgeons they don't. So it's very personal views, and both will work. And using it has some beneficial. And sometimes for the parents having these appliances, it's reassuring. If we leave these clefts open and we don't initiate any treatment, usually the parents get a bit worried. So having these appliances, most of the time I see they are reassuring for the patient, for the parents especially. So it allows the correction of the flattened nose before the surgery, and it also facilitates the nose repair when they are repairing the lip as well. So there is a very weak evidence on the pre-surgical orthopedic, if you have to do it or no. But as you can see here, there is this paper, they found out that the NAM is in combination with the GPP reduce the need. They found that it reduced the need for secondary alveolar bone grafting by 60% in patients with unilateral cleft lip and palate. So when you have unilateral cleft lip and palate, depend on the severity and the width of the cleft, the success rate of the bone graft is affected. So the narrower the cleft, the higher the success of the cleft lip, of the bone graft in the cleft palate, unilateral cleft palate. So here they found that 60% of these patients, they come to that they don't need the secondary bone grafting later on, which was interesting. And this is another paper also. They found that this NAM, it facilitates the primary surgical repair of the nose and lip to heal under the minimal tension and reducing the scar formation, improving the aesthetic results. When we need to do the lip repair, that's the first surgery usually done for the cleft lip and palate patients. There is a rule of 10. When the child is 10 weeks and 10 pounds weight, and the hemoglobin level to reach 10, that's the best time to do a first surgery of the repairing the cleft lip and palate, which is the lip repair. So don't forget the rule of the 10. And usually that's around the 3 to 4 months of age. And usually the type of the repair that is done, or it's the rotation advanced procedure or flap they do just to approximate these areas. But still they might need some plastic surgery later on in future in life. So again, during the infancy, the palatal closure can also can occur when the child is 6 months to 18. So after having the first surgery, which is lip repair, then we have the palatal repair at the age of 6 to 18 months. It depends on the severity of the cleft palate, and depend if it is associated with syndrome or not. In some syndromes, such as Pierre-Robin syndrome, the palatal repair is delayed to allow the further development of the mandible and improve the patency of the airway post-operatively, post-surgery. So the impact of clefting on the oral health now. So let's look now how it's going to affect the oral health. We discussed the dental anomalies that the cleft lip and palate they have, malocclusion, crowding, supernumerary, hypodontia, hyperdontia. So these children, other than having a cleft lip and palate, dentally they are really vulnerable and at high risk. For the caries, there is a weak evidence. They found that the cleft lip and palate, they have more caries. That's very common sense. Why? Because if you look at the tooth quality, it's much lower. They might have hypodontia, hypoplasia or hypomineralization. Also the crowding, it does not allow having a proper oral hygiene during the early life, and having the scar in the areas of the lip repair also will constrict the lip, and that prevent the proper brushing of the front teeth and the crossbite. And some parents also, they are really worried about the traumatizing the cleft area. And they really are, they come and say that, doctor, I cannot brush. I'm scared of brushing near the teeth which are in the cleft area or near to the cleft. I'm afraid that it's caused some complications. And we usually reassure them and tell them that it's not going to happen, and it's very safe, and there is no any risk of brushing teeth, even if the cleft is not repaired fully. And the primary dentition also, they found that the cleft lip and palate, they have 1.5 more DMFT score, and the permanent dentition, it's also 1.3 or more in the cleft lip and palate. So really they are at higher risk of caries. So prevention is very important to prevent these to occur. And going back to now, other than the dental caries, if you look at the periodontal disease, it's very common to have gingivitis in cleft lip and palate, or cleft palate only, especially in the upper area. That's because it's very quite hard to brush. And if you see this patient in your clinic, even the examination on the upper anterior area, it's quite difficult to examine. And when you think of the brushing, it's not easy, but it's doable. We have some other alternatives of brushing the teeth, but we need to give them the credit of that. But at the same time, we need to motivate them and educate them on the proper brushing technique. On the periodontitis, there is not enough evidence on if they are at higher risk of periodontitis. But if you look at the cleft area, due to the bony defect, many teeth get more periodontitis, so bone loss. Other than the defect itself, the environmental or surgical procedure which is done sometimes the teeth, they get some weakened more from the periodontium point of view. So the oral health of these children usually with the cleft lip and palate, they have higher dental caries because of the anatomy of the cleft area and because of the misaligned teeth, and also because of discrepancy that they have in the skeletal base relationship. Also due to the surgical repair, surgical bone grafting procedure, hypoplastic defect, scarring, and also several orthodontic treatment. Keep in your mind that the orthodontic treatment, it might start very early in life. And other than having this misaligned teeth and crowding ectopic teeth, having an appliance in mouth, that will require further efforts in maintaining the oral hygiene for these children. So the dental care of the children with cleft, usually they have an increased prevalence of the caries. So we need to consider the higher fluoride and early in life. The minimum fluoride content in each toothpaste, before the age of 3, I can say that's 1,000 part per million, and after the age of 3, the minimum, it should be 1,450. You can control the risk of the fluorosis if you're worried about with the amount of the toothpaste that you use, but keep in your mind that they are at very high risk of caries, and most of them they don't have that kind of regular follow-up, since they are very busy with other surgeries, other follow-ups because of the ear infection, speech therapy, and they have other complications. And every week they have 1 or 2 appointments. So it's very common for them to miss their appointments for the preventive measure that you do in your dental office, like fluoride varnish or fluoride gel. So it's very important to work the prevention, more concentrate on the prevention at home than if you than concentrating mainly in the office. You can do all your preventive measures when they come and visit you, but don't forget the most important prevention. It's for them. It's at home. The oral hygiene and diet counseling is very important. Their teeth are already weakened by hypoplasia and hypomineralization. So reducing the teeth which reduce the pH in the mouth, it's very important. And also we need to familiarize them very early with the dental environment, because these children will be visiting the dentist very early in their life, and their behavior, usually they visit dentists 10 times more than the normal individuals, having in mind that they keep on going through many surgeries and visiting different physicians with different procedures. Most of them, they are coming already with an anxiety to see you. So working on the having a child-friendly dental environment is very important. And due to surgery, due to scars, and due to cleft, usually most of them, the sulcus depth usually it's very shallow. That's a challenge if you want to work. Also, also the other challenge is that when you're working with the child, is the cleft area. They have high gagging reflex, and the water might go through the communication. If the cleft palate is not fully repaired, the water will be communicated between nose and oral cavity, and that's very annoying to them. So my suggestion for that is to use a rubber dam or dental dam for these children whenever you are using any handpiece or any 3-airway syringe, because that's very uncomfortable for them. But keep in your mind that most of them, they have nasal blockage. So be very careful when you're using the rubber dam. Try to use a sectional or keep it open from one side so they can breathe, because most of them, you find them, they are mouth breather because of the nose deformity and the nasal polyps, they are mouth breather. So that's a modified brushing technique that you use. One of the instructions just to, you have to tell them to raise the lip and brush the teeth because normally they cannot do that because of the stiffness of the scarring on the lip. And the other alternative is that to ask them, especially if they have crowding and they have teeth on the cleft area, to ask them to use the interdental brushes, like you see in this picture, to clean their teeth. Since they are at high risk of dental caries, it's very common that you see that they lose their primary teeth very early, and usually the complication that is associated with that is it's worsen their space condition and the space loss, and it complicates the future orthodontic treatment. So it's very important that to try to preserve the teeth as much as you can, and that's guaranteed by having a good preventive measures early in life. And also it is preferable to restore the primary molars with the stainless steel crown. The best is to use now a hole technique, then extract them. Hole technique will provide the child-friendly, less time, no local anesthesia. But if you are using on the E, keep in your mind that most of the time sixers will erupt in ectopic eruption, so try to use it as small as possible, or if the child is cooperative enough and you can use a handpiece with the water, you can do the, I highly suggest you to use the modified hole or conventional stainless steel crown to reduce the chance of possible ectopic eruption in these children. And always we have to monitor the incisor relationship because of the scar that they have on the upper lip and the constriction and due to collapse that they get when they have the cleft area. Usually the teeth, they collapse and the jaw collapse, and so they usually have the class 3 incisor relationship. And the fissure seal the molars and premolars as soon as they erupt. And mind that the lateral incisors in the alveolar area, in this 50% of the cases, it's missing. So they have hypodontia, and think of the replacement. And with you need to work interdisciplinary with your orthodontist to see how can you manage the missing lateral. Either you would do your bone grafting earlier and you allow the canine to erupt in the area of the lateral, and that's a natural space closure. So whenever you want to do any restoration, consider child behavior and age, and use the minimal intervention dentistry. We are using SDF a lot for treating their teeth, and we are using hole technique and atraumatic restoration with close follow-up. So try to be to have very minimal intervention and child-friendly to consider their behavior and future acceptance in case of any emergency. Also, the caries management should be carried out before any orthodontic treatment, and keep in your mind that they should be fit for ortho treatment from the oral hygiene perspective and the dental caries and plaque. Keep in your mind that the enamel quality and quantity is lower in these cases. So whenever you are using adhesive restorations, keep in your mind that your bonding might be affected due to the poor enamel quality. And always consider the cost effectiveness of the treatment that you are doing. These children usually they go through many treatments, many surgeries, and doing a cost-effective treatment, considering the cost in your treatment and discussing that with the parents in advance is quite appreciative for parents when you do that. during the primary dentition, you have to reassure them, the parents, and inform and prevent and acclimatize the children. So that basically it's the behavioral management and proper diet and oral hygiene. Avoid extraction if it is possible, and keep up with the medications. Many of, 20% of the cleft lip and palate are associated with syndrome. So keep in your mind that they might have other systemic or medical conditions, and communicate with craniofacial team very closely. In a mixed dentition, where we have our interceptive orthodontist, usually that's the expansion period of the secondary alveolar bone graft. What happens in the cleft lip and palate is the cleft area collapse, and the area for the bone graft is very small, or it's an inadequate for the canine to erupt that. So expansion is quite helpful in that instance. So we need to consider the anterior crossbite correction. Either we use the face mask or removable appliances. And we as a pediatric dentist, for us, the most important thing is to maintain the oral hygiene and brushing and pit and fissure sealants of the molars. So bone grafting, it has many advantages, as you can see. So it's quite important to do the bone grafting in an ideal time when you can get the maximum benefit, and that's before eruption of the cuspid or the lateral incisor. When is the best time to do? Usually when the canine roots are either half or 2/3 form, and usually that's between the age of 7 to 10, but in most of the cases we do that around the age of 9. And if you have to do it earlier, if the lateral incisor is present. So that's the case that you can see here, the cleft area. And after expansion, you created enough room for the bone graft, and here the bone graft has been placed. And now the canine can erupt in a bony alveolar area. We highly recommend taking OPG, usually at the age of 7, because you can see at that stage, that's the early mixed dentition stage, maybe you might have any supernumerary teeth in the cleft area, or to rule out if you have hypodontia, because in case that you have hypodontia, especially when the lateral is missing, then you might, as we said earlier, you might do your bone graft earlier at that stage to allow the canine to erupt in the area of the lateral. So here you can see the both upper laterals are missing, so the bone graft was placed earlier. But before that is the palatal expansion. We do the palatal expansion before the bone graft. And also during mixed dentition, as we said, to correct the malocclusion, we use the face mask, which is also called the reverse pull headgear. And here that you can see that after 4 months of reverse full headgear, that you can see that the occlusion has been corrected, and the maxilla has been advanced. Keep in your mind that other than bone grafting at the age of 7 to 8, there are many other surgeries that need to be done later in life. After the cleft palate surgery, 10% of the cases they end up with having a fistula. And later in life, usually at the age of 7 to 10, or sometimes with the bone grafting, you might consider repairing the fistula. And the nasal tip, usually it's reconstructed at the school age. And when the child is 8 to 10 years, as we said, that we do the bone graft. And the final repair of the lip and palate also it's done during the child's mid-teens age. And usually they need to have also regular hearing checkup, because the hearing, in many cases, the hearing is impaired. So in permanent dentition, now we delegate most of the our job to our colleagues in orthodontic department. Now they need to go through comprehensive orthodontic treatment that involve correcting either anterior posterior relationship or transverse relation in case of they have crossbite in these cases, or in correction of the hypodontia or spacing, all done at this stage, final stage when they are at the permanent dentition. For us as a pediatric dentist, it's very important to maintain the oral health during orthodontic treatment and educate about the hypocalcification of the teeth and hypomineralization also. It's very common to have in this case. So how to maintain them with having orthodontic treatment, it's very important. So now we come to the conclusion. As we discussed, the cleft lip and palate, it's really an interdisciplinary team. You need to have your team and you need to communicate with your team very closely. And it starts from the prenatal stage up to the adulthood. So you need to consider many aspects when you're planning your treatment. For us as a pediatric dentist, it's very important to look how the child is being fed. So feeding might be difficult for these children, and we need to consider that these children their diet has not been changed due to their feeding behavior. So it's very important to look into their diet, because their feeding is not very easy and comfortable for the parents to feed them. So many times they change their diet, make it more calories and with high sugar content because of the taste, and they that's a price to them. If they do brushing, they get a lot of present with the chocolates and the lollipops. So we need to consider their feeding and their diet, and consider their hearing in your practice. Many of them, they might have hearing impairment. So in these cases, communication is very quite important when you communicate with your children. Since they cannot hear you well, you need to make sure that they understand what the procedure that you are going to do. The normal tell, show, do, the tell component might not work. So you have to show them every step, demonstrate that to them to gain their trust, and consider their psychology and refer to the social workers if needed, and make sure that you exclude any safeguarding and neglect. It's very common to have the child abuse for children with these impairments and these conditions. So it's very important to rule out any child neglect or any child abuse. And the most important thing for us is the prevention, to start very early, to try to preserve the teeth. And because even extraction of the teeth, we will lose the bone. So if you extract the teeth very early in life, you won't have that high quality bone for the bone grafting or the correction of the cleft later on. And if you have teeth on the cleft area, and if you want to extract them, it's preferable to extract them within 3 to 6 months before the bone graft. Why is that? First of all, if you do it too early, you will have the bone collapse and bone loss. That's not good for the bone grafting. And if you do it too late, there won't be any healing. So you would have the socket of the tooth, which require far more of the bone grafting. So to allow proper healing, so better to extract the teeth on the cleft area 3 to 6 months before the bone grafting, to allow proper healing of the bone, and not to lose the bone due to early extraction of these baby teeth. So I hope that it was not boring to you. I know this topic, it has a lot to talk about, but I try to concentrate on our role in pediatric and our colleagues in orthodontist, to know exactly what we are going to do. So thank you for listening. Thank you so much. And please go ahead if you have any questions. And you can email me if you want any further, guideline or any articles. I can share it with you at any time. Just email me.
Thank you very much, Dr. Anas, for a wonderful, very informative presentation. It was really clear, all the points, and it's really a challenge to treat these kind of patients. And it's really important to have a very good team to deal with these cases. We can start with the first question. There is a question about stem cells. Could it be used to improve the palatal repair?
Definitely, the stem cell has a big role in that, but I haven't come across any study that they use a stem cell for the palatal repair. That would be very interesting to know. But a stem cell has a role in any kind of defects, I mean, to answer that, there are some the intrauterine surgery done to repair that. So the future of the cleft lip and palate is that they do the repair before the child before birth. So the surgery or the advancement in our surgery that we have, we can repair the surgery before birth. So hopefully we don't need but that's still under the studies. So in few areas of the world, they are doing that intrauterine surgery, but the stem cells definitely would have. I haven't seen any cases that has been treated with stem cells.
It will be really interesting to know if this will work. Another question we have is what's the best time to close the cleft lip, and what's the best time to close the cleft palate?
For the cleft lip, it starts earlier in life, during the 3 to 6 months. Usually, as we say, the role of the 10, when the child is at the 10 weeks and 10 pounds, and the hemoglobin is 10. It starts earlier. And for the cleft palate, as we said, depend on the severity of the cleft palate and plus minus if it's associated with the syndrome or no. You will start you can do it from the 6 month to 12 month. And one more important thing that we consider that is the airway. As I said, in Pierre-Robin syndrome and some syndromes, the airway might be compromised after surgery if you do it too early. So you need to wait for some development of the mandible, so to have a patency of the airway. So that's one of the other than the cleft size, it's to look at the airway. To decide what's the best time.
Okay, great. Another question, how can we manage hypoplastic teeth in cleft patients?
Well, yeah, that's a very important question because these teeth, the children, they have hypoplasia. So in case of hypoplasia, we can use adhesive restoration, but the aesthetic might be compromised. Since the enamel quality is good, but the quantity is low, so adhesive restoration is one of the cases, but in one of the treatment options. But in most of the cases, usually you can see the hypoplasia and hypomineralization mixed in one tooth. So a full coverage, if it's a primary molar or if it's a first permanent molar, full coverage with stainless steel crown is my preferable treatment option.
Great. There is one question about one is surprised to know that the most important part of the cleft lip palate team in the UK is the nurses. So what do you think about that?
Sorry, Dr. Masoud. you were lagging the connection, but I couldn't hear you well.
The most important part of the cleft lip palate team in UK is the nurses. So what's your comment on that?
Yes, I do agree that in the UK, the nurses, they are the first to greet these children. So most of our behavioral management is done by the nurses there, and they are they are involved in the counseling and oral hygiene instructions when it's come to oral hygiene instructions and counseling. So they are one of the important members in the nurses in the cleft lip and palate. They really have a good. They put a lot of effort in the behavioral management. Surgeons are too busy. They don't have that time, or they don't usually put that much of effort, unfortunately, in the behavioral management. So we can see most of these cases are behaviorally managed initially by the nurses. And also one more important role of the nurses in the UK is to exclude if there are any safeguarding issue or neglect. There are nurses specialized in that. So they really look into if the child is having any suspicious to be neglected, either oral or dental negligence, or the general health of the child is neglected. So they are the first individual usually to, because they have all the data of the child. So they are the first person just to, if they found any suspicious case of neglect and safeguarding issue, to report it to the social workers.
Okay, I think because of the time, we will just have the last question. How can we manage deep bite in these patients?
Usually, because of the deep bite is due to the cross bite and class 3 and class 3 incisor relationship and collapse of the maxilla. The maxillary expansion and correction of the cross bite, usually it's correct the deep bite, and with having usually deep bite, it stays only until during the mixed dentition stage. And the final correction is, which usually it's minimal deep bite you have when you reach to the permanent dentition. If the skeletal correction is done earlier in life, so if you have done the skeletal correction of the expansion and correction of the posterior cross bite and advancement of the maxilla is done earlier in life, usually that gets corrected during mixed dentition. And minimal correction is usually required by fixed orthodontics later during the permanent dentition.
Great, thank you very much. I think
so much.
To start with our second presenter. Thank you very much, Dr. Anas, for being with us, for accepting to give your presentation in our webinar society sessions. And hope you stay with us till the end of the second presentation. Dr. Ali, can you take over? Thank you very much. Dr. Ali Zahrani.
Thank you, Dr.
Dr. Ali Zahrani, I think you need to unmute, please.
Thank you, دكتورة منال. صوت كويس الآن؟
Yes.
Okay.
We can hear you.
On behalf of the Saudi Society of Pediatric Dentistry, we'd like to welcome our distinguished speaker, Dr. Ahmed Masoud. Dr. Ahmed is a clinical assistant professor at King Abdulaziz University. He is a diplomate of American Board of Orthodontics, and he had the PhD in neuroscience and sleep from University of Illinois at Chicago, and he is their adjunct professor. Dr. Masoud is a reviewer for many journals like The Angle Orthodontics and the American Journal of Orthodontic and Dentofacial Orthopedic. He has invited to speak in international meetings such as the American Association of Orthodontic and the World Sleep Congress and the American Academy of Dental Sleep of Medicine, and where he has the award, the Graduate Student Research Award. Dr. Masoud tonight will speak about maxillary canine impactions. Working together is a success. I would like to welcome Dr. Masoud, and for any questions or comment to the speaker, please send it to the Q&A at the bottom of the screen. Further, Dr. Masoud.
Thank you very much. Can you hear me properly?
Yeah, fine.
Okay. Okay, thank you. And thank you very much, Dr. Anas, a very sensitive and important topic. As yourself and Dr. Manal said, it's having a good craniofacial team that works well together, I think, is the most important thing. And this flows well with the general message of my presentation, that working together is success. So this is the outline of this webinar tonight. We'll start with the definition and etiology of canine impactions, maxillary canine impactions. So what's an impacted tooth? An impacted tooth is an infraosseous position of this tooth after the expected time of eruption. In contrast, a displaced tooth is an anomalous infraosseous position of the tooth before the expected time of eruption. The canine is considered impacted in general if it's delayed beyond the age of 14 to 50. This is the most used definition. However, there are other definitions. There are multiple definitions, but these are two of the most other common ones. An impaction is defined as a failed eruption of a tooth with a completely developed root. So if you see here, even this canine root, if it's developed, even if this patient is 10 or 11, it's considered impacted based on that definition. And another definition is if further eruption may not take place based on clinical or radiographic diagnosis. So if you look at the third molar here, again, even if this patient was 15 or 16, you don't expect this tooth to erupt. So based on their definition, we call this an impacted tooth. So again, dental age will differ based on your reference. I have this from Wheeler's Dental Anatomy. I use this because this is the easiest to memorize. So in general, the maxillary canines erupt at the same time as the second molars at age 12. And this is the the eruption timing. So at age 6, you get lower centrals and first molars, 7 upper centrals, lower laterals, 8 upper laterals, 9 lower canine, 10, 11 first and second premolars, and finally at age 12 you get the canines and the second molar. So that's the age you should look for the canine. Look for the canine to erupt, not start looking for the canine. So the etiology of maxillary canines impaction is several factors. These are some of the factors. First is insufficient space. However, this is a main factor in labial impactions, not really a factor in palatal canine impactions. The second is factors related to the primary canine. So the primary canine fails to resorb or is lost too early. That can result in an impacted maxillary canine. The third is factors related to the maxillary lateral incisor. So if the maxillary lateral incisor is absent, is malformed, hasn't erupted in time, that can be a reason to get a maxillary canine impaction. The fourth is factors related to the maxillary canine itself, if it's dilacerated or if it's ankylosed. And finally, genetics. So as you see here, this is the basic classic picture of a palatal canine impaction. As you can see here, there is enough space for the canine to develop. This is, of course, a primary canine. The permanent canine is here. So there is space, but it's still not in. So as you can see here, 85% of palatally impacted canines have sufficient space. So insufficient space is mainly a factor in labially impacted canines. There are two major theories for the development of canine impaction. The first is the guidance theory. The guidance theory says that the canine erupts along the root of the lateral incisor. If the root is absent or malformed, the canine will not erupt. So what I tell the students, just to make it easier to remember, imagine the canine is a beautiful princess waiting for Prince Charming to come and sweep her off her feet. So Prince Charming is the lateral incisor. If the lateral incisor or Prince Charming doesn't show up, is late, has a malformed face, a malformed body, then our princess will go upstairs, stay in her room, and won't come down. The second theory is the genetic theory. So genetics are the main origin of palatal displaced canines. This just links several, things, observations we see. So if we have a missing or small lateral, there is genetic correlation between that and an impacted maxillary canine. So based on this theory, the missing lateral isn't physically the reason for the impaction of the maxillary canine. It's not that the maxillary canine wants to erupt along the root, it's just linked by genetics. Another thing is enamel hyperplasia is also seen with maxillary impactions, infraocclusion of primary molars, and finally, congenitally missing premolars. Next, we'll talk about the prevalence and sequelae of maxillary canine impactions. So maxillary canines are the second most commonly impacted teeth, second, of course, only to the third molars. They have a long path of eruption and erupt late. So 2% of the population has impacted maxillary canines. They're twice as common in females as in males. They're more common in the maxilla, and 2/3 of them are palatally, so palatal impactions are more common than labial, and most of them are unilateral. So to remember the prevalence, I always just look at this picture. So this has the general prevalence, so a female, palatal, maxillary, unilateral. So if you just remember this, you'll remember it's more common in female, maxilla, palatal, and unilateral. So what about lower canines? Although this isn't the topic today, but lower canines are much less common, 0.1% to 0.4%. So the maxillary is 5 to 20 times more common. However, ironically, this year, I've seen 6 lower canine impactions. Of course, if I have 6, then ideally I should have, based on their prevalence, I should have seen 3,000 to 6,000 cases this year, and I can assure you that's not the case. I think I'm just lucky that I'm getting a lot of these canine impactions. So the sequelae, usually canine impactions are asymptomatic. However, you can get things that develop, such as a cyst, an infection, root resorption, migration of neighboring teeth, loss of arch length, and loss of attachment. So as you see here, this isn't my case, but this is an interesting case report. This is a cyst related to the canine. You can see how massive this cyst is. Of course, they took it out along with the canine. So if the patient is younger, not an adult, I think canine impaction should be managed as soon as possible. As the patient grows, some 30, 40-year-olds, if the canine is there, it's asymptomatic, you can at least watch it. But in general, managing canines should be done as soon as possible. Second is root resorption. As you can see here, they usually resorb the lateral incisor, but in this case, it's actually resorbing both central incisors. And this also shows it. Third, loss of arch length. You don't have the canine, so the teeth tend to drift forward. The molar, the premolars drift forward. This side becomes class 2, and you have crowding now. And then loss of attachment. As you're pulling the impacted canine into the arch, you might get loss of attachment, loss of gingiva, loss of bone. And so before you start, always tell the patient, I mean, this may result, I can't promise you the canine will look beautiful, but you might have this, you might need the gingival graft. So based on all this, that's why managing canine impactions should be a collaboration between all dental specialties. So GD and PD or PDO are in a proper position to diagnose and intervene early. The oral surgeon is needed to expose and bond or extract if needed. The orthodontic, of course, is for traction, and perio for a flap, gingivoplasty or gingivectomy, or even a gingival graft if we have loss of attachment. Next, we'll go into clinical and radiographic diagnosis. So the first step is to diagnose the impacted canine clinically. So what do you have to look for? Look for an over-retained primary canine. Look for a bulge, a labial bulge. You have to start looking for the labial bulge at age 9 or 10. So if you don't see a bulge, that doesn't mean the canine is impacted, of course. If you don't see the bulge, there might be an eruption disturbance, so you have to take further investigation, take an x-ray, So of course, it doesn't mean that the canine is impacted, but if you take an X-ray, you see the canine looking like this, then you can tell the patient, okay, there is an impacted canine, we want to start doing something. And this is what the canine bulge looks like. This patient is 12. He's slightly, I mean, this is the proper time that the canine should come in, so you should find this bulge. Third is a palatal bulge. If you don't see the canine, run your finger across the palate. You'll feel, so here there is a canine impacted here, a palatal canine impaction, and you'll see that this side is bulging more than this side. With your finger, you can probably even feel it more than see it. And finally, distal crown tipping of the lateral incisor. So why does this happen? This patient is 12 years old. If you look at the pan, the canine pushes against the lateral root, so the crown goes distal. However, what happens if you see this distal crown tipping at age 8? At age 8, it doesn't mean anything, because we all know, of course, I'm speaking to pediatric dentists, that this is the ugly duckling stage. So the crown of the lateral should be tipping distally, but as the canines erupt, it should then become straight. If, like this patient, he's 12, you still see this, then there is something wrong. So these are the 4 factors you look for during clinical diagnosis. What about radiographic diagnosis? Radiographs are key to evaluate canine eruption. You want to know if it's displaced, if it's, where is it erupting? Second, you want to evaluate the root of the lateral incisor, or even the central incisor. Is there resorption or not? You want to take an X-ray to know where you should, or mainly the surgeon, where the surgeon should go in to access the canine. Is it labially? Is it palatally? Is it behind the central? Is it behind the premolar? And finally, we as orthodontists want to know which direction we should pull the canine in. Sometimes you need to pull it distally, sometimes you need to pull it laterally first, so it depends on how the canine is positioned. These are the X-rays we take to diagnose our impacted canines. The first and most commonly used, of course, is the panoramic. So in the panoramic, you want to evaluate 4 things. You want to see how the canine is in relation to the lateral. Is it overlapping the root of the lateral incisor or not? You want to evaluate the vertical position of the canine relative to the lateral, and then the angle, and then the apex. So we'll talk more about that in evaluating prognosis of the impacted canines. But these 4 things, when you look at the pan, you need to look at these 4 things. What about CEFs? So CEFs aren't really alone, not a diagnostic tool for a canine, impacted canine, but it can help along with the pan. So at age 8 or 9, the maxillary canine should be parallel to the maxillary central incisor. So here it's normal. Well, if we look at this CEF, you can see this canine going out almost through the nose. So of course we know this is not normal. And this can also help you in terms of where to access for exposure. So you don't want to go in the palate. Here you might need to go from the labial, tie the canine here, and then bring it down. And next, periapicals. So periapicals, you need them, and you need to use the buccal object rule. I'm sure most of you are aware of that. Same lingual opposite buccal, slob. So you take one X-ray, and then you take another X-ray. If the cone moves distal and the crown moves distal, then the object you're looking at is lingual. And always, because this gets confusing when you're looking at 2 X-rays, you want to evaluate which one was taken first. So I always do this regardless of how many times I do it. Always fill the blank. Cone moved blank, object moved blank. So I'll show you what that means. So this is an impacted canine. We want to know if this is palatal or buccal. So let's start with the general object, the buccal object rule. So the main idea is you're taking an image of 2 images that are superimposed against each other. As you move the cone distally, the palatal object should move distally. So same lingual, and then the buccal object should move in the opposite direction. And this is the classical example. So this premolar has 2 canals. Of course, we only see 1. So you take another periapical, and how do you evaluate if you went mesial or distal? So here I can see the canine 3, 4, and 5. Here I see the 2, so which means the cone moved mesially. And then I see 2 canals now. So this canal here that moved mesially, moved in the same direction, is the palatal. So the cone moved mesial, the object moved mesial, so this object is the palatal object. In terms of canine, again, here we see up to the central lateral. So we took another image and we can see central lateral and premolars, which means the cone moved distally. Now we look at the canine. The canine here is touching the central. Here it's not touching the central, so that means the canine also moved distally. So the cone moved distal, the object moved distal, then the impaction, of course, is palatal. The third image we use is the occlusal image. So the occlusal radiograph, of course, the best 2D image for evaluating of labiolingual position. CBCTs, of course, are better, but not every center, not every office has access to a CBCT. So if you don't, occlusal images can be very useful. And last but not least, of course, CBCT scans. They're very important to locate the canine accurately, to assess the damage or resorption, access for surgical procedure, direction of orthodontic forces, and amount of bone surrounding each tooth. It comes with some disadvantages. The cost is slightly, it is more expensive than a 2D image. Access, like I said, not every center has access to a CBCT. The radiation dose is higher. It can be 2 to 3 times, sometimes 4 times the radiation of a pan. And acquisition time, however, nowadays this isn't a big factor because CBCTs are getting faster and faster. So let's look at this patient. So this patient has a canine here that's displaced, at least, if not impacted. You take a periapical, you can't see anything. Take a CBCT, you can tell accurately where this canine is coming. It's coming above the lateral, tilting mesially, so you can perfectly diagnose this canine. Another case, you look at the pan, it's resorbing the centrals. Take a CBCT, you can navigate. The root of the lateral and the central is completely gone. So in a case like this, if you see the CBCT, you'll probably say, well, we're extracting both of these and just bringing the canine in their place. And like I said, access for surgical procedure and direction of application. So again, the pan, you can't know where you want to access, buccal or palatal. You see here, it's definitely easy for the surgeon to know where to access the canine. And in terms of orthodontics, I need to know where I'm pulling the tooth. So here, I can't just pull the tooth labially. I'm hitting the root of the lateral. The first step is to pull it distally until I'm away from the lateral incisor, and then I go labially. This is another case of the CBCT scan. So again, it's very high above the lateral, central. As you can see here, it's touching. Again, same thing, I pull the canine away from the incisor. So you need to know the proper direction of force. And because, of course, CBCT scans are 3D images, you can see things that you usually don't see with pans. So this was one of my CBCTs during my PhD, one of my research subjects. So if you look here, you can't see anything. If anyone else can see it, I'm impressed, but I can't see anything that's happening here. I feel everything looks okay. I was doing the CBCT to evaluate the airway. So we look here, you find 2 teeth here, 2 supernumerary, either supernumerary or impacted canines. But you look here, they're more clear. They look like they're 2 teeth running away from the mouth. And so incidental findings are important with the CBCT scans. So that's why CBCT scans are a double-edged sword. Although they give you very important information that help you in terms of diagnosis, if you take it, you need to properly evaluate the CBCT scans. Because some practitioners nowadays take it routinely and don't look except at the thing they want to look at. If there is something that you missed, you are held accountable. So you're legally required to look at everything in the CBCT scan. Next, we're going to talk about prognosis. So this is what I was talking about when you're looking at a pan. These 4 factors you need to memorize. So overlap of the lateral incisor, the vertical height, the angulation, and the position of the apex. So in terms of poor diagnosis, if the canine is completely overlapping the lateral, is completely above the apex of the lateral incisor, is 30 degrees relative to the midline, 30 degrees or more, or the apex is above the second premolar, then this maxillary canine impaction has poor prognosis. So let's look at examples. So this patient here has a canine that's impacted. If you look at relative to this table we said, so it's not overlapping the lateral. It's not above halfway above the lateral, so it's just within halfway the root length of the lateral. The angle is not that bad, it's 15 to 30, and the apex is almost above the premolar. So this has a good to average prognosis. This was easy, we just opened space and the canine came down without even exposing. What about this case? We look here, we look at the overlap, completely overlapping the lateral incisor. It's not very high, which is good. So it's halfway the length of the lateral incisor. The angle is bad, it's above 30 degrees, and the apex is above the premolar, which is acceptable. So this was an average case. This case took about 2 years, was a palatal canine infection. Other case, if you look at this case, the overlap is complete. So this is poor in terms of overlap. The height, it's high, but it's still not above the apex, so it's here. The angle is good. It's less than 15 degrees, and the apex is good. So this case was not very hard, but we opened space, it didn't come down, but because it's very high, we needed, of course, to surgically expose it. Another case, let's look here. Overlap is bad. I mean, poor prognosis, so it's overlapping the lateral and even some on the central. The height is above the half of the root of the lateral. The angle is over 30 degrees. The apex is above the 4. So in terms of prognosis, this is average. Here we just opened it, exposed it just with a gingivectomy. So this was a very easy exposure. And here you see this canine, this is not common. So here we have the overlap, of course, is nothing. It's perfect in terms of overlapping the lateral incisor. It's not overlapping the lateral incisor at all. The height, it's a bit high. The angle is great. However, the apex is above the 5. And in cases like this, where you have one of the factors being very poor prognosis, it might throw off the whole case. So here, I don't know of any orthodontist who might try and bring this here. So here you have 2 options, either extract it or bring it in the place of the 5. And finally, this case, so in terms of overlapping the lateral and the central, the height, it's a bit high, the angle is bad, and the apex is good. However, as we said, one factor here, the overlap was very poor. So it's not just overlapping the lateral or the central, it's overlapping the central on the other side. So in this case here, we needed to extract this canine. Okay, next we'll go into interceptive management. So the ideal form of treatment with best long-term results for impacted canines is early interceptive management. So examples include extraction of the primary canine or resolving crowding by expansion or braces. This is a key article, and I think every dentist should know this paper. So it's by Erickson and Kroll, 1988. This study was done on PANS, and they found when they extracted the primary canine, if the canine, the permanent canine, was distal to the midline of the lateral incisor, it came down in its position 91% of the time. If the permanent canine was beyond the midline of the lateral incisor, and you extract the primary canine, there's a 64% chance that the canine will drop in its place. Of course, chances of normal eruption decrease if the angle is above 30 degrees. So let's look at this case. Let's look at 2 canines here. This canine is overlapping the lateral. So here, there is overlap. The canine was extracted, the primary C was extracted, no orthodontic treatment whatsoever. The canine came in perfectly in its position. Next is resolving crowding by expansion or braces. So you need to create space to assist in canine eruption. Again, remember, crowding is more important in palate and in labial impactions. So expansion or braces with a coil, you need to create space to have the canines come in. With expansion, you can use any type of expander. I'm fortunate to have used all these types of expanders. They all have different advantages or disadvantages, but the main objective is just to create space, and they all create space. So let's look at this case. Here, the canine is also impacted. Here, we just use braces to open the space because this is an easy impaction. Canine came in perfectly, very nicely. Let's look at another case. So this was a 9-year-old boy. The canine is not ectopic. However, you don't have any space for the canine. So if we just leave the canine as it is, it might get displaced, it might get impacted. So we just did a 2x4 open space, at least, so the canine now has enough space to erupt. So we'll just give the patient a retainer, have the canines come in, and this patient might not need orthodontic treatment at all. So 2x4 might have been enough. Okay, so these were examples. However, of course, you can combine these two. You can extract and expand or open space. So let's look at this case. This is a case with a very ectopically erupting canine, overlapping the lateral. The angle is bad. And it's not very high, but this is has an average to poor prognosis. The C's were extracted and the arch was expanded. No braces. If you see here, the angle went from almost 45 degrees to almost 10 degrees. Nothing, it just, fixed itself on its own. So this is very important, and I think pediatric dentists should attempt to properly diagnose these, and I think they are. The angle improved very much. Okay, this is another very interesting case. Look at this 9-year-old boy, or girl, sorry. The canine is almost horizontal. So, and if this patient was an adult, this is a very, very hard case. But this is a 9-year-old girl, so you can extract the C, but again, you don't have space for the 4. So in this case, the C's and the and D were extracted. Again, I'm going to show you this has no orthodontic treatment whatsoever. It's amazing how the canine just, the 4 came down and then the canine just shifted and went down very nicely. This is a cousin of mine. That's why this is a case close to my heart. So I saw this patient at 26 years. He was living abroad and he came to me and I saw the canines. I'm going to show you them in a bit. But when I saw them, I wanted to go and see his old records. So I took out his pan from 15 years ago. This is a pan from when he was 11. Let's look at the canines. Here, the canine isn't overlapping. Here, it is overlapping. So in hindsight, I didn't see him at age 11, but in hindsight, if the canine is overlapping the lateral, I would take out the canine. So this was never done. And let's look at him now. The canines just decided not to come in. They're almost horizontal now. The primary canines are still in. So now it's a very difficult case. He has 2 canines, 2 palatally impacted canines. So extracting the C's I can't guarantee that it would have helped, but it probably would have, maybe, I'm not sure. Okay, last is orthodontic management. So orthodontic management, I'm going to talk about labial impactions, palatal impactions, and finally extraction. Labial impactions are our best friend. We like labial impactions. They're easy to treat. Patients love how the results turn out. So the main concern with labial impactions is to bring the tooth in attached gingiva. This is based on the level of the canine, how high the canine is relative to the mucogingival junction. So if the canine is mostly below the mucogingival junction, you can just do a gingivectomy. So I sometimes do these myself because you see the canine, you can feel it. If you just use a blade, open a small window, the canine will come down. If it's mostly above the mucogingival junction, then you need an apically positioned flap because you want to make sure the canine comes down with attached gingiva. And finally, if the canine is really high, then you need closed eruption. So you want to expose it, close it, and bring it down. Next, so like I said, the most important is bringing the canine in attached gingiva. However, opening space is very important. Sometimes when you open space, you don't need to expose it. So in this patient, this canine was impacted. This patient, I think, if I remember correctly, was 19 years old. The 6 was extracted. It was hopeless. So as you can see here with the progress, no exposure, nothing, just by pulling the 6 back, the 5 and 4 back, the canine has improved a lot. So the overlap went from total overlap to halfway overlap. The angle went from over 30 degrees to between 15 and 30. And the apex went from above the 5 to above the 4. So the prognosis is much better now. without exposure. Another case showing how opening space in labial impactions is very helpful. Here it's overlapping the lateral and even the central here. The angle is bad. Again, this, I'm not presenting on sixes, but I have a lot of first molar extraction cases. This is a topic for another day, but here we had to extract the 6. As you can see here, retracting the 4 and the 5, the angle improved a lot. The overlap went from full to halfway. The angle improved from over 30 degrees to almost less than 15. And the apex also, it was above the 4. Now the apex is in the proper position. The opening space is very important before attempting to expose, in my opinion. A lot of the time, they just come down on their own. You don't need to surgically expose. And the problem with high canines is they're high. So with labial impacted canines. So if you just put a wire, just biomechanically, the canine wants to come down, the adjacent teeth will want to go up. So if you just put a continuous wire, you'll get this. A high canine, if you don't think, you don't try and add anything, you'll have an open bite. So if you see here, there's an open bite, shallow bite anteriorly, and an open bite on both sides. So that's why we use auxiliaries to help in terms of bringing the canine down. You can either use a coil spring to move these, the premolar and the lateral away. This way they don't tend to come up. Use 2 wires, a base wire and another wire. Use elastics to bring the canine down, or use a cantilever. Next, we're going to talk about palatal impactions. We do not like palatal impactions. So palatal impactions are the cases, I mean, next to first molar extractions on the lower, I usually don't tell the patient the treatment is going to be less than 2 to 3 years. So again, it's a long treatment time. It depends based on the prognosis of the tooth. It takes 2 to 4 years depending on the difficulty. The steps is 1, to create adequate space. Create adequate space, so the reason we created adequate space for labial impactions is for the canine to come down on its own. Here, we're not expecting the canine to come down. We just want to create space so we're ready when we start pulling it out. So the next step is to surgically expose the canine. And I use a gold chain. There are other methods, but I just, when the surgeon exposes it, I want him or her to bond a gold chain. And then we start pulling the tooth, orthodontic traction. So open space, expose, and move. And the canine is a big tooth, and it's within the bone. So this is a case, this 19-year-old didn't have anything except for an impacted canine. Everything looked perfect. So I didn't want to mess his occlusion up. So we exposed it. It's very close to the lateral. So the first step to me was I want to pull it distally. So I want to keep everything as is. So I bonded this cemented this TPA and bonded it to the 5, 7, 5, 7. So I'm almost pulling the canine against 6 teeth. And even with that, everything moved forward. So if you see on the right side, this side was class 1, now it's class 2, while pulling the canine back. It's an easy fix. Now I need to bond everything, but I give the patient class 2 elastics. But this just demonstrates how big and how hard it is to move the canine. So this is the same case that I just showed you in steps. So we bonded the appliance, exposed, started pulling the canine distally more, and then once we're fine, we start pulling it labially. Once we're out, we start choking it with a heavy wire, and it's done. This took 2 years. And these are other things we can use to bring the canine down. So a Kilroy spring, 2 wires, same as I just showed in the labial impaction, a mouse trap, ballista spring, or a cantilever. And finally, there are cases, of course, where we have to extract the canine. Everyone's sad, but it might be the best option. So when do we extract? These are the 2 main reasons. If there's an unfavorable position for the canine, a completely horizontal impacted canine, or the patient just refuses to go through treatment just because of the length of the treatment. I don't want to go through 2, 3 years of treatment. I want to finish in a year. So of course, we give the patient the option. We tell them the canine might be the better option, but if he refuses, we can't do anything. We have to extract it. If the canine is affected anatomically, it might be dilacerated. We might consider extracting it. Severe crowding, you're extracting a tooth anyways, a premolar maybe, and then the canine has poor prognosis, it might be better to just extract the canine. And if the C has an acceptable appearance. So if you decide to extract the canine, you need to manage this space. So these are what you need to do. You either protract the premolars. So you have to move the premolars forward and substitute the canine with the premolar, or put the premolar in the canine space. Implant, auto-transplantation, and finally, if the C is kept in its place, you have to inform the patient that the C might eventually be lost. So so let's say you decide to extract the canine, the C has a nice appearance, so you want to retain the deciduous canine. That is a valid option. Why? Because the canine, the roots of the deciduous teeth usually resorb as the permanent teeth grows. In case of a very poor prognosis, or if you decide to extract the canine, the roots of the canines, the primary canines, will be intact. So I usually try and finish my presentations with a nice case as a wow factor, but unfortunately here I really want to finish with this paper. It's a very important paper. This group assessed root resorption in retained C's, D's, and E's in patients with severe hypodontia. They had PANS in these patients from 0 to 40. They had hypodontia with no permanent successors for the C, D, and E. They had 356 patients. And if we look here, let's just focus on the C's, because this is what we're looking at, the E's and D's. I mean, it's a nice paper. If you haven't read it, it's a nice read. So let's look at the canines. The lower primary canine has better prognosis than the upper. In 70% of the cases, there is little or no resorption up to the age of 40. So up to the age of 40, there's almost no resorption in the primary canine, and it can stay in its place. In the upper, it's slightly less. It's almost 60% with little or no resorption. Almost 10 and almost 15% here of these Cs will have resorption above 75%, which warrant extraction. So 60 to 70% of these canines will stay. But again, always protect your back. Inform the patient that these Cs might eventually be lost. So no one can whistle a symphony. It takes an orchestra to play it. And meetings like this Saudi Paediatric Society and other orthodontic societies bring us together. So coming together is the beginning. Keeping together is progress. And finally, working together is success. So this brings me back to the title of this webinar, which is working together is success. We need to make sure we can work together, work well together, and throw our egos out the window. Thank you, and I'll take any questions if you guys have it.
Thank you, Dr. Ahmed, for your informative lecturing. And we will start with the questions. First questions. The audience asking, they say they thank you for your nice presentation, and he said that when you put 2x4 in the case, there is lower lingual arch and all the permanent teeth are erupted. Do you think there is need for it? She mean the lower lingual arch.
It depends on the case. If I feel the lower canine if I have enough space for the permanent canine to come in, and if it's erupting properly, I don't always put a lower lingual arch. If the canine on the bottom is also ectopic, which might be the case with an ectopic upper canine, then I'll put in a lower lingual holding arch to make sure I fix both canines.
Okay. Another questions. What is the routine radiographs you use in your clinical practice for diagnosis such displacement?
So the pan is the first thing I take. So I know others take CBCTs on everyone. If I know there's a canine impaction before I see the case, sometimes I'll just go ahead with the CBCT. Like if the patient comes in and he or she has seen someone else, I'll just take a CBCT, because from the CBCT I can extract the pan, a ceph, and everything. But if it's my patient, the first time I see the patient, the first thing I'll take is the pan. If I need further investigation, then I'll take a CBCT.
Okay, clear. Another question, if you have a case of impacted canine that is causing external root resorption of lateral incisor? What treatment options you have?
First thing I do is I cringe because I don't like seeing those. It depends on how much resorption there is. I mean, even if I've had cases where the resorption, the root length to the crown was 1-to-1, and it stayed in nicely. So the first thing I'll do is evaluate the case. If I don't have any crowding, if I have crowding and I'm taking out the teeth anyways, I will consider taking out that lateral incisor. If the case doesn't warrant extraction, like in general, it's not an extraction case, I'll try to move the canine distally and evaluate the lateral incisor as I go. If it's still 1-to-1 or better than 1-to-1, I'll keep it.
Yeah. Another question is, do you think the auto-transplantation of canine is a treatment option?
I haven't had any cases of auto-transplantation. It is an option, but I know it comes with complications. It can get ankylosed. It requires 1 or 2 surgical procedures. It's not easy, but it is always an option. I don't have any cases though.
There is another question, the same, so that means it's hot topic. They need clear answer.
I shouldn't have mentioned it.
Okay. When you should close the diastema with 2x4 if you fear that the canine will be impacted? So, I mean, in the case of ugly duckling stage, I think.
Yeah, so if only if I feel the canine is ectopic. So if the canine, that's why I don't go in unless the canine looks like it's overlapping the lateral, or if there's completely no space. If there is space, I have a diastema, I'll just take a pan and monitor the patient. I'll take another pan in a year and see how the patient has evolved. If there is completely no space for the canine, then I'll put a coil and close the diastema and use the diastema space to help the canine to erupt properly.
Okay, good. When the patient requires an exposed bone, usually we write consent to write some consequences, such as failure of bonding, tooth may not move, and what are the risks you usually encounter with A and B with golden chain, for example, in your case, the previous case with the golden chain traction?
So luckily, the case I showed, the gold chain stayed on for the 2 years. But you do have cases where the gold chain, of course, debonds. If that, although to my surgeons, I always tell them, put as much composite as you want. I want that chain to stay on there. I want to remove the chain myself. The other thing, I have a case I'm doing now, and it's not running as smooth as the one I showed. We exposed the canine now 3 times. Every time we expose, and the chain is still on there, but every time we move the tooth, it's still like the gingiva overgrows and we can't move the tooth. So if you're talking about complications I get is gingival overgrowth. As you move the tooth, sometimes the tooth falls into the gum. But I haven't had debonds in terms of gold chain. But of course, in terms of consent, I'll always tell the patient, treatment won't take less than 2 years. Expect 2 to 4 years. Expect you might have some attachment loss. You might have some recession on the canine as we bring it in. I'll use low forces, but there is still a chance that we will have attachment loss.
And they will accept another surgery and to attach the chain.
This patient was nice, so I'm fortunate. If I know some patients will just blame it all on you and tell you didn't do your job. This patient was very. She was educated, she was aware of the whole situation, and she saw that we were pulling the canine, and every time the canine comes down, it goes up again. So she understood, and she even said, I want to have another surgery.
Good. Another question is, how often you review the maxillary canine traction? I mean, he's asking about
in terms of follow-up visits? Yeah. If I'm using power thread or gold chain, I see the patient every 3 to 4 weeks. But if I'm using a cantilever, because a cantilever has a long range of action. So you can leave a cantilever in for 6-7 weeks and the canine will just move. Or even when you use 2 wires, the NITI is active for a long time. But I still always see them in 4 weeks.
Other questions. Studies show that labial displacement are more common in Asian population. Do you think the same apply in Saudi Arabia? There is a study in this field?
I am not aware, but I feel in terms of labial impactions, a lot of them can be overdiagnosed. Like sometimes it's crowded and you just open space and the canine comes down. Some will diagnose this as a labial impaction. To me, it's not always a labial impaction. Sometimes it's just a tooth that needs space. But I'm not aware. I'm sure there is, but I am personally not aware of of a study that shows the prevalence here.
There is another question. It's not totally related, but I will mention it if you have answer. What would be the management of dilacerated root? I think he's related to the canine. If the canine is dilacerated and not erupted, what is your management in this case?
So the first thing is I'll tell the patient it might take more than 2 to 4 years. It might take, if I'm bringing the canine down, I'll tell them 3 to 5 years, because you have several options. If bringing the canine is the right treatment option, then I will try to bring it in, but most of these cases, as the canine comes down, the dilaceration disappears. So as you're bringing the canine in, a lot of the tooth with dilacerated tips, the tip resorbs. And sometimes it doesn't resorb, it comes down. If it's a huge dilaceration, I have to show this with my finger. If it's a huge dilaceration, it might even push against the lateral. So if it's a huge dilaceration and it doesn't resorb, you might have to finish the canine in an angle so that the tip isn't touching the adjacent tooth.
And complete removal is not an option?
If extraction is the right option, again, I will propose it. But if the patient doesn't have crowding, the patient has enough space, the face can't afford extraction, then I'll try to bring the canine in. If it doesn't move, of course, yeah, but you'll tell the patient that there is a chance of extraction. So if the canine just doesn't move, you have to go back and reevaluate.
Another question for the case of 2x4. By using 2x4 to close the space, do you expect the lateral to move against canine, which will increase the possibility of its resorption?
Very important, very nice biomechanic question. So because of course, as you push the lateral incisor toward the central, the crown moves mesial, the root moves distal. In a lot of those cases, I tilt the bracket. So before I start, I push the root of the lateral mesial. So I'm pushing it away from the canine. So while I push the lateral, I'm pushing the whole tooth bodily. I don't want the root to go distally, as the question, good question.
Okay. What do you think of case with one labial and other palatal displaced canine?
I haven't seen any, but that's you have to have two brains because every canine will have different treatment methods. So it's an interesting case, but I haven't had any.
Dr. Ahmed, thank you very much for your presentation, for your discussion. We enjoy it, and I'd like to appreciate your time and effort.
Thank you very much for having me.
Thank you. Dr. Manal, are you with us?
Yes.
Mike with you.
Yeah. Thank you, Dr. Ahmed. Thank you, Dr. Ali, for moderating the session with me. Thank you, Dr. Ahmed, for the very nice presentation. It's a pleasure to present this certificate of appreciation in the name of Saudi Dental Society for Dr. Anas Al-Salmi for being with us today, and also for Dr. Ahmed Masoud for your great participation, and hope we will see you again in other, probably other symposiums or conferences here in Jeddah. And also we would like to thank our moderator, Dr. Ali Zahrani, my colleague and dear friend. Thank you, Dr. Ali, for being with us today. And like with two nice presentations. So hope to see you next week, same time at 8 o'clock. And if you have any questions, we will be having the emails of Dr. Masoud and Dr. Anas in our website. And so you can ask them any further question that you need. Thank you for being with us, all our audience. And hope to see you again next week. Thank you very much. It was a pleasure, Dr. Anas and Dr. Ahmed. Thank you.
شكرا لكم الله يعطيكم العافية.
Thank you so much. شكرا يعطيكم العافية وإن شاء الله we'll meet soon again إن شاء الله.
إن شاء الله.
استودعكم الله في أمان الله.
مع السلامة.